What I did present is the role of bone marrow microenvironment niche, especially in the myeloma progression, because we know we're all wondering why some patients with an MGUS, this pre-malignant condition, evolve to myeloma and others don't. So what I was trying to achieve during that 10 minutes is really try to understand what make a patient progress to another, they stay with this precondition forever. And the point I was trying to raise is I don't think genetics or the tumor is what really changed. I will say it's probably the bone marrow microenvironment, because there is a kind of a subtle balance that in some patients they always constant and allow the myeloma cells to stay under control. In other patients, this unfortunately is not the case. And I thought, and to mention the key players that we think in myeloma and in the bone marrow niche are key. And I mentioned, for example, the role of MGUS, these immunosuppressive cells, that they are in the bone marrow, and they are unfortunately the one helping the Treg to emerge, or inhibiting, for example, the T cells. Of course, I talked about T cell exhaustion, because some patients, because we have this antigenic stimulation present in the bone marrow, have these T cells with less fit and therefore less proliferative and able to capture the myeloma. So I think we're just start to learning how equally important is the bone marrow microenvironment, not just the tumor. So there, of course, other, we were talking about strategies to improve immune therapy, and among them is, of course, combination therapy to help other cells, not just the T cells, to help with the response. And you could probably tell from the audience question too, how everybody still try to ask how we can identify the progressor and not progressor patient, how to define them in routine. And I would say right now we're still probably at the beginning of learning that, but definitely in the few years probably we'll have a signature that we can use in a routine practice.